All right, welcome back, everyone. Think of this whiteboard explainer as your ultimate coach's playbook. Look, you've already put in the hours, right? You've read the chapters, done the late nights, and now it is time to totally elevate your thinking. We're moving away from just rote memorization and stepping fully into real clinical judgment for your pediatric nursing final. You've got the knowledge. Now we're going to learn exactly how to apply it when the pressure is on. Okay, here's our game plan for this synthesis. We're going to cover the golden rule of prioritization, red flags and recognition, navigating conflicting source data, high-yield clinical scenarios, and finally, we'll hit some rapid-fire exam traps.
So, Section 1, the golden rule, prioritization. Let's dive right into this. Across every single system we've covered, whether it's musculoskeletal, integumentary, or psychosocial, one foundational truth remains absolutely crucial. Airway, breathing, and circulation dictate our first moves, every single time. Take this scenario, for example. A child arrives with suspected physical maltreatment, an obvious head injury, and is entirely unresponsive. It is so incredibly easy to see the word abuse and immediately jump to reporting protocols, right? Like calling Child Protective Services or questioning the caregiver. But what do you do first? While abuse is a massive legal and psychosocial issue, you literally have to think clinically first.
Here is your exact priority sequence. Stabilization always precedes interviewing. A child with a possible intracranial injury, they can deteriorate in a matter of seconds. Therefore, maintaining that airway, ensuring their breathing, and checking their neurologic safety takes absolute precedence over documentation or legal reporting. You simply can't interview a caregiver if the child doesn't even have an airway. Remember the order: ABCs, neuro, physical assessment, and then only then your objective documentation and reporting. This quote from Professor Dyer perfectly captures the essence of this rule for major thermal injuries, like a house fire. It's so easy to get bogged down on an exam trying to calculate total body surface area percentages. But don't let the math distract you from the immediate, life-saving clinical framework. If a child is pulled from a fire, their airway and 100% humidified oxygen come first, followed by fluid resuscitation. The actual wound care for those burns, that is absolutely the last step in your initial emergency response.
Moving on to Section 2, red flags and recognition. All right, there are 6 vital components of the neurovascular assessment, or the Ps. We've got sensation, skin temperature, color, capillary refill, pulses, and movement. This is a massive, high-yield topic, whether you're dealing with a fracture, a cast, or traction. So the crucial point here is this: you must always compare the affected extremity to the unaffected one. That side-by-side comparison is literally the only way you'll catch a subtle delayed cap refill or a slightly weaker pulse that might otherwise seem completely normal if you were just looking at it in isolation.
It's also critical to differentiate between 2 very different causes of recurrent fractures. On one side, we have physical maltreatment, which often presents with an implausible story or, say, bruising in an infant who isn't even walking yet. On the flip side, we have osteogenesis imperfecta, or OI. That's a genetic collagen disorder characterized by fragile bones and blue or gray sclera. So here's the big exam trap. Multi-stage healing fractures require deep detective work. Do not automatically assume a child is being abused without considering a medical condition like OI. But, on the other hand, do not assume that just because a child has OI, they're somehow immune to physical maltreatment. You always have to assess objectively.
Section 3, navigating conflicting source data.
Let's tackle something I know causes a ton of anxiety: conflicting source data. It happens. Textbooks get updated, lectures highlight different statistics, and suddenly you're staring at 2 completely different numbers in your notes. Just take a breath. We're going to focus on why understanding the underlying concept matters far, far more than picking one correct number. Here's a classic example with Duchenne muscular dystrophy, or DMD. Your ebook explicitly states life expectancy is around 30 years. Meanwhile, the lecture notes assert it's less than 20 years, like late teens. If you see this discrepancy on a practice test, do not panic. And please do not get stuck trying to guess which number the software prefers.
And this brilliantly illustrates the real strategy here. You need to zoom out to the core concept. The highly testable clinical takeaway is that DMD is a progressive, life-limiting neuromuscular disease that eventually leads to severe respiratory and cardiac failure. That physiological reality holds true no matter which specific age is listed in the multiple choice options. Grasp the disease process and you'll get the question right for sure.
We actually see the exact same thing with burn assessments. One source describes deep partial thickness burns as having sluggish blanching, while another says it flat out does not blanch. Again, do not agonize over the descriptive adjectives. Focus on the anatomical depth. This specific burn involves the entire epidermis and extends deeply into the reticular dermis, damaging hair follicles and glandular tissue. If you understand the anatomy of the injury, you understand the burn. And hey, the exact same logic applies to source discrepancies regarding scoliosis bracing versus fusion thresholds. Don't memorize just one number. Understand the progressive severity of the spinal curvature.
All right, Section 4. High-yield clinical scenarios.
Let's lock in these essential burn rules, because these come up all the time. First, you must premedicate before wound care or physical therapy. Why? Because you need the analgesic to actually take effect before the peak procedural pain hits. Treating pain reactively is just ineffective and honestly traumatic. Second, use cool or tepid running water to stop the burning process. You might see different sources argue over the exact wording of water temperature, but the core concept is universal. Never, ever use ice. No way. Ice causes aggressive vasoconstriction, cuts off blood supply to already damaged tissue, and can plunge a small child straight into hypothermia. Lastly, always leave those blisters intact to protect the underlying skin.
Now, regarding contact dermatitis, if a child touches poison ivy, we usually treat it with topical creams or maybe oral prednisone for severe cases, kind of like how you'd see specific meds like permethrin for scabies, methotrexate for systemic autoimmune issues, or isotretinoin for severe acne. But if someone throws poison ivy into a campfire and burns it, the urushiol oil actually aerosolizes. If a child inhales that smoke, it is no longer just a simple skin rash, it is an immediate, life-threatening airway emergency. Airway swelling from inhaled urushiol has to be prioritized instantly.
Section 5. Rapid-fire exam traps. Okay, we have reached the final stretch. I need your full focus here. We're going to run a rapid-fire gauntlet of the most common, most dangerous exam traps that always trip students up. This first one is arguably the biggest trap in the burn unit. Less pain does not equal a less severe injury. A superficial partial thickness burn hurts terribly because the nerve endings are exposed but still intact. But a full thickness or deep tissue burn, it might have absolutely zero pain. Why? Because the thermal injury was so severe that it completely destroyed the nerve endings. An absence of pain in a severe burn is a massive red flag for deep tissue destruction, not a sign of a mild injury.
Let's rapidly run down the rest of this checklist. Unexplained spiral fractures. You know the ones from a twisting motion or bruising on an infant who can't even crawl yet? Massive red flags for maltreatment. Next, applying butter or home greases to a burn? Never do it. It just traps the heat inside the tissue and breeds infection. For compartment syndrome, remember that the earliest warning sign is severe pain that is totally out of proportion to the injury and is not relieved by standard pain medication. If a child with a neuromuscular disorder, like spinal muscular atrophy or cerebral palsy, suddenly develops a weak cough, new choking, or cyanosis, that is a respiratory emergency. You prioritize that airway immediately over any long-term mobility concerns. And speaking of prioritizing, if you see signs of anaphylaxis, epinephrine is your priority before anything else. Period. Wow, you made it through the playbook. You've reviewed the pathophysiology, you've memorized the core assessments, and most importantly, you've just proven that you can elevate your thinking to real priority setting logic. You know exactly what a nurse must do first to keep a child safe.
So, I leave you with this final, provocative thought as you head into your exam. When the question is complex, the data is overwhelming, and you have 4 answers that all look partially correct, what is the foundational priority that will always, without fail, guide your very first action? Trust your training, remember your ABCs, and go conquer that test.